Good morning, good afternoon, or good evening to wherever you are and watching and joining us today. My name is Dr. Raymonde Uy. I am the Physician Informaticist at the National Association of Community Health Centers. Welcome to our LinkedIn Live discussing and using occupational data as a driver of health. Today, we will be talking about the value of occupational data for health, or the ODH framework, for health center patients and care teams. Joining me today is Dr. Michele Kowalski-McGraw, or Dr. Kowalski, who serves as an Associate Physician Diplomate and the Department Wellness Director at Community Care. She is also an Occupational and Environmental Medicine physician at UC San Diego Health. Thank you, everyone, for joining us today, especially in this virtual world. Please feel free to comment and ask questions in the chat. We will do our very best to answer as many as we can during the Q&A section at the very end of the program. This LinkedIn Live will be recorded and will be available on the NACHC page and the LinkedIn page after the event is over. So we do have a lot of things to cover in the next 25 minutes. So let's dive right in, shall we? Dr. Kowalski, thank you again for joining us. And why don't we kick things off by just really an explanation. What exactly is ODH, or Occupational Data for Health? And why should we care? Why is it important, not just for you, but for me and community health center staff as well?
So first off, Ray, I really appreciate the chance to be here with you today and talk about this, and the chance to work with National Association of Community Healthcare Centers on this. Because as an occupational medicine physician, I see every day how important work is to your health. We spend up to a third of our lives at work. In an 8-hour day, it's a lot of time. So I've heard that, zip code is as important as genetic code when we come to look at health and the factors that environment has on health. But you think about it, you're not always home, you're at work, and even if you're in the same zip code, you're exposed to very different things, both good and bad. In general, work is good for health. We know from data that, if you're working, then you're active, you're healthy, you're likely also able to do a lot of other things too, which is what we want for our patients. But nonetheless, there's hazards at work as well that need to be captured and, addressed. And unfortunately, until we had this framework called Occupational Data for Health, we didn't have a way to do that. So now with this new framework that NIOSH has created, we can capture work information in an interoperable way. And this is patient-centered. This is what the patient tells us, and they know that it's going to be used to help design a care plan for them, and then also for populations that they are part of. So it's really exciting to be able to do this now with the framework that NIOSH has created.
Yes, I hear you when you said, Michele, that we spend 8 hours of a 24-hour work. That's 1/3 during the weekdays that our workers are spending just doing work. And then 8 hours of that is spent maybe sleeping, and the rest is really every other responsibility that people have. So those 8 hours at work is really crucial, and because it takes a lot of our time doing that. So we've seen the value, OEM physicians, providers, PM&R, those people who touch patients, who do these kinds of works and with well-known conditions. With the Occupational Data for Health framework, although people know the value, are there policies that kind of push the vendor's hand in really implementing or supporting ODH? Are there any policy and law, legislature, anything like that?
Yes, that's been a big thing over the past 2 years. The core data for interoperability was created so that we know what to put in the medical record. Everything is electronic these days, so we have to have actionable data, understandable data, something that the computer can capture and the people understand, and that can mean the same thing, whether you're in, California or Maryland or Texas, wherever you go. For instance, I have a lot of patients that may be seen away from their workplace or home. And when they show up in the urgent cares or emergency rooms, they need to know, what these people do, whether they're a pilot or a firefighter or what things are going to affect their work. So US CDI, US Data for Core Interoperability, has adopted occupation and industry as core data elements in version 3. So we're very excited that this is going to be a requirement moving forward. And I think, again, this is how we help populations, how we advance data and really reach some underserved populations. ODH was created over 10 years ago when the Institute of Medicine, which is now the National Academies of Science, Engineering, and Medicine, realized what a big tool this would be in really addressing health disparities, improving patient care overall. So yes, it is in regulations. We're excited about that.
Yes, and I think that's a major success for those healthcare workers on our LinkedIn Live today. We generally ask the patient what work they do, and it goes into a free text field in the social history section, right? But because of you're saying, Michelle, with US Core Data for Interoperability version 3, which includes employment status, occupation, and industry, is going to be mandatory to be interoperable across different EHR vendors. Yes, and if I recall, there is also the Office of the National Coordinator for Health IT's HTI-1 proposed rule, which mentions US Core Data for Interoperability version 3 in the ruling. So that's, I think, what you were speaking about, Michelle. Yes?
Yeah, absolutely. I'm glad you mentioned the free text because work is not often captured in many encounters besides occupational medicine. I realize there's not a lot of time in the average primary care and certainly not emergency visit to capture all this. If it is in the record somewhere, it would be free text. And that's not accessible to, the moment that you need to care for this patient. So yeah, we really are trying to move away from that free text and get it to be up to speed.
Absolutely. And then you think about it when a patient goes to the doctor, they take time off to see their provider, right? And then the next thing they think about is, am I able to go to work the next day? Or how long will it take for me to recover? So which brings me to the next question. So how does collecting ODH or work-related information really impact patient care and outcomes? Like what you have seen in the field, the really practical applications, because we all know it's all about patient outcomes, patient care. What have you seen, Michelle, like in your practice and with your colleagues?
Yes, so with National Association of Community Healthcare Centers, I had the opportunity to work on a great pilot where they really did target who their patients were that were developing respiratory problems. And they found that, a lot of them were farm workers. So again, if we find that information, then we can act preventively. And that's what's really exciting to me, because in occupational medicine, sometimes I get these cases, and they already have whatever they have. And I think, if only we had known what they were exposed to, ahead of time, then we could have prevented this. So the farm workers is a great example. If they are being exposed to a lot, then perhaps respiratory protection, different environmental controls would help. Certainly when we're caring for patients, medications are a huge issue, especially for those safety sensitive jobs like truck driving or airline pilots. And I know my patients complained to me, the doctor didn't know that I was a pilot or that I was a truck driver. So, knowing that would be huge.
Oh, most definitely. I've seen patients like that as well, where they need to use their hands, and they use their hands a lot for their work. But if they have injury with their hands or what they use every day as tools for their work, then it really impacts them a lot. And there's a lot of discussion also, Michelle, about work information as a social driver or social determinant of health. Can you speak more about that idea?
Yes, yeah, I'm very happy to see that we are recognizing these social determinants of health and how important they are. Because again, in my practice, I think that you can't really care for the patient unless you see everything else that's affecting them. So yeah, I'd like to call your attention to slide number 5, I think it is. That shows that all the things that we are capturing as social determinants of health. I think it's the next one after that. You can see on the left-hand side here with Healthy People 2030, all the social determinants of health that are being recognized, which is great. And so economic stability is one of them. But I want to point out that's not enough. because if you look on the right-hand side of the slide here, this was just from Indeed.com, but all these jobs, 25 jobs, all pay the same amount. So, they could be all, economically stable. However, you can see that the exposures would be vastly different, from a firefighter EMT to a sales manager or, web developer. So yeah, we need to know economic stability, but that's only part of it. Your job also determines, your access to insurance, your time off, your ability to access wellness events, your social network, basically. So again, you can see, even though these jobs all pay the same, it could be very different what the benefits are and what the exposures are too. So yeah, work in and of itself is a very important social determinant of health.
I'm really glad you brought that up, Michelle. As you know, there's a lot of employer-sponsored health insurance plans, right? And that's employment. So when you're unemployed, you can get maybe, Medicare if you're Medicaid, sorry. And depending on your work situation or employment situation, it really affects it has a lot of downstream effects in the way you live, because you have to pay your health insurance out of pocket without employment a sponsored insurance. So that I see that to be a big detriment to people actually going to seek care because of the cost that they incur. But if you set up their prevention and policies that may be in place to protect these occupations and workers in these industries.
Yeah, great point. And not to mention even just vacation and sick pay, are they willing to come to the doctor because they'd have to take time off of work? Sometimes if they don't have that vacation or sick pay, they can't do that. So unfortunately, it's often the same groups that are marginalized and have other social determinants of health that are at risk that are occupying the jobs that don't have good benefits. So with this new occupational data for health program, we can really reach those people, no matter where they are encountered in the medical system. We can see what they're exposed to, both the physical, chemical, psychosocial, all the things that they're exposed to based on their work.
Absolutely. Which brings me again to this is a very important question that I'm sure some people know. Now that we've established the value of collecting occupation, collecting the industry that you work in, and your employment status, and all of these variables that are tied to these data elements, what are concrete next steps that a community health center staff can do, even if they are not at a level where they can do this big decisions? For example, I'm a health center staff. I really believe that specific occupations and the people we see in our community health center I'm seeing a lot of asthma. I'm seeing a lot of these kinds of injuries or conditions. But some people will say I'm not in a position to do anything. But what can we advise these folks who want to support these endeavors, occupational data for health and data elements? What can they do? What's the first thing they need to do? First, 1, 2, or 3 things.
I think the biggest thing is the education, from all the way from the person that checks the person in at the front desk to the providers themselves, and then to the informatics people that create the system that we work in. So a lot of people do understand that work is important, but they may think it's already in there somewhere. And they also have privacy concerns too. The patients themselves, who are you going to share this information with? I don't know if I want everybody to know where I work. They have to realize this is health data. This is the same as any other protected health data. The fact that you have high blood pressure or other social determinants of health, it's going to be protected in the same way. So that's a big education point right there, that once we integrate it in, it's used for health. We have other ways of knowing where people work, but that's not integrated with your medical record. And I think that's the whole point. So I think that's a big education piece right off the bat, is to have everyone understand that. And then the other big thing is that I understand, as somebody who sees patients, you only have 15 minutes. You have another patient coming right after that. You have to put everything in the medical record. The way that NIOSH created this program is really patient-centered. So the ideal way is to have the patient offer this information, to have it in there before you're seeing the patient. And to have it used in the informatics way, through clinical decision support tools that pop up, or even in retrospect, looking at populations. So I think that education piece too is important, where we realize we're not, we realize it is another data element that we're asking you to collect, but there's ways of doing it that are not going to be a clinical burden. So I think that's an important thing to look at. How are you going to get this data? We realize it is going to take some time to get it, but ideally, a lot of that is patient time, and when we do ask the patients what they do, again, I think that they need to know we're going to use this to really tailor their care, deliver better care to them. So that's an important one too. Then again, just moving up, making sure everyone is on the same page with this, seeing the workflows, not you and National Association of Community Healthcare Centers. Certainly you guys are good at pointing out not every clinic is the same. It's not going to work a cookie cutter way. So you need to keep seeing how this is being done, what the teams are experiencing. Again, we don't want it to be a burden. We want people to be excited about this. We don't want people to feel threatened in any way, because again, it is protected data. And then once you have made that hurdle, then train the trainer approach does help. Once you get a couple champions on board, they can then educate everyone else and address any concerns that arise.
Absolutely, Dr. Kowalski, and it's great that you mentioned first and foremost was it's training. And I'm sure there are some folks in this who are watching this right now, again, are already thinking about, oh, it's again, like you said, another thing to collect, and it has to be the provider, or it takes away our staff time just to ask this one more question, and then it all piles up, right? But in the ODH guide, when collecting this information, it specifically mentions a way for the patient to enter this information by themselves while they are waiting. Well, so it really depends. You have to do some human-centered design, I think, to really think about the workflow tailored for each health center. Like you said, Michelle, different health centers, different workflows, different scenarios and situations, and different bandwidth and staffing time. So really, I think starting from there as well, like you mentioned. And another thing you mentioned, Michelle, was telling staff how to ask that question. There's, like you said, reluctance of patients to share this information. We've seen this in the past 2.5 years with a project with 3 big health center controlled networks. They had to do network-wide training so that staff will understand the nuance of asking. And just like Michelle, like when you talk to your patients, right? You let them know that your information is secure, nothing will be done. This is really for public health and for policy making. So there. Yes. So yeah, go ahead.
Yeah, and I was going to say, it really is a great way to connect with your patients. If it's presented in the right way, really, that's what we're looking for, right? In this era of medicine where everything seems to be moving away from that patient-centered care. When you think about it, when you meet somebody, you ask them, what do you do? So again, it's a way to connect with your patients and really just start talking with them. And again, work is where they spend a lot of their life. So, as you start talking to them, you learn a lot about them just by knowing their work.
Oh, yeah. Which again, our next kind of our final question, we're kind of wrapping up because we're kind of reaching the Q&A section. But before that, this is something I'm sure in everyone's mind right now. Would be I would again encourage folks to ask any questions on the chat while we transition to our last question. So we have about 10 minutes left. Michelle, past 3 years, I'm sure, has been kind of a haze for some. It's been really tough kind of past 3 years with the COVID-19 pandemic. There was a lot of discussion during that time about essential workers and essential industries. So how does, supporting the ODH, or Occupational Data for Health framework, contribute, for example, to disaster preparedness? And how does this help support our essential workers, for example, during the pandemic, those in the front lines who had to use full PPE to see patients? Like, how does collecting this occupation, industry, and employment information help with that in the future? Knock on wood, no more pandemics, but for any general disaster preparedness or emergency preparedness.
Yeah, as you said, hopefully we won't have anything like that again. But if there was any silver lining, it made us realize what we were missing. And one of those big things was, who are our essential workers? when we wanted to get the country running again, we wanted to get those people out there, get them protected, get them what they needed, but how to identify them, really, there was no way to do that. So I think that was highlighted, and part of what helped us to, start working more aggressively on this particular project. Once we know who are the essential workers, then we can say, hey, there's a vaccine, we're going to prioritize you for it. Or this is the amount of personal protective equipment we'll need because this is how many essential workers we have. So yeah, it would. Hopefully we won't need to use it on that scale again, but I'm sure we will have use for it in the future in terms of really finding out who needs protection the most. And just one other point, these again, these are jobs that are not always the biggest benefits or the most robust employers. Some of them are mom and pop type operations. So to be able to help with that and really say, here's what your employees need is huge.
Absolutely. And again, I'm encouraging anyone in the call to ask questions or any comment that you want. I wanted to bring this up, Michelle. This is this is a really prime example. So one of our viewers who is in Louisiana, who commented like in Louisiana, in the Delta north of Baton Rouge is quote unquote cancer alley due to worker exposure, they said. And where the commenter was located in Dallas, where the PM is about 2.5 in concrete batch plants, is driving asthma and probably cancer as well. And the comment was that the needs of these workers aren't being addressed. So in this way, in using ODH, just collecting this information, how do you think that can help, for example, for these?
Yeah, these are great examples. And again, I want to emphasize that this is going to be de-identified data. So privacy is protected. We're not trying to target any particular employee or employer, but we do need that aggregate data because we need to know how many people are having this, what is the exposure. So when we can link that, when we can put that occupation and industry in with all the other factors that are in the medical records right now, that's a big thing. So that's a great example of cancer detection and really addressing moving forward. How do we prevent this?
Yeah, and that again, that big barrier, and this is a personal experience, is that most of this information, because they're in free text, you have to get someone to actually sit down and look at each and read each individual paragraph and narrative to look and find that specific data element or domain. Like where's occupation, where's industry in this big pile that they copy pasted in their EMR somewhere in their SOAP note. There are informatics tools we can use, right? Like natural language processing to parse that. But again, those are additional steps that you need to parse through free text. What I want to share right now with the viewers is a resource. So on the left, you are seeing a technical report. This is a product with CDC NIOSH, which is a guide to the collection of ODH, tips for HIT system developers. It has a nice mix of technical and introduction for ODH. If you go to the CDC NIOSH website, it's very easy to find this resource. You can also find us in our blog post, as well as an action guide. You're seeing it on the very right. So NAC work with Dr. Kowalski and the CDC NIOSH in these past 2.5 years to create an action guide, which will give you concrete first, second, third steps. So for you to get started, you don't have to be technical. This is something just you can get value. You need that leadership and to create that value for people who are higher up that can actually make a change in terms of policy. So, Dr. Kowalski, what roles are you aware of that lead to the initiative of collecting social drivers of health data, for example, this kind of work-related information? What typical community health center roles do you think would be able to lead this? I'm thinking first QI or quality people. But from the clinical side, what do you think? What roles? Who do you think are needed the most to be involved?
Yeah, that's a great question. And I think we need to involve the clinicians themselves because they're the ones on they're on the boots on the ground and see how this works. So, we've seen through our pilot that we've had some really great clinicians that have, felt passionate about this. And data is power. But, as you pointed out, we have to have quality data. It can't be just free text that we have to keep digging for. So I think, when you're engaging that staff, really get the clinicians to speak up about what they're experiencing. And then also realize, I have to, true confessions, when I first started the project, I thought this was in there and the people are already addressing this. It's not, it's siloed. Work information is siloed right now.
Yes.
So we need to get it in there so we can use it, and really getting that case made, that it can't be just free text. It has to be something that we can use in that point of care.
Yeah, absolutely. And, we are thankful we have policies that are in place, ruling that may affect the next 2-3 years, where ODH is in fact going to be required, because in the technical specifications in US CDI version 3, it is, again, for our viewers out there, it uses ODH. What drives change with our EHR EMR vendors would be demand. So we're approaching it in two ways. There's a policy aspect, and there's also demand from staff. So you really need to start that conversation. Doesn't matter if you're a data or not data or technical person, you need to find that liaison that's speaking with your vendor so that they are aware and they know that there is demand for this type of information.
Yes, and from the clinician side, again, we have so much we have to do in that 15 minutes, that the more that the computer, that informatics can help us, the better. But we need the programs to be created so that that we can have the information in there to help us.
Yes, and again, for everyone here in this call, we're here for you. So NAC and CDC NIOSH are here to help support your endeavors. If you want to go through the steps, you have any questions, please just send us a message. We are very friendly, and we're going to get really excited to help you out and get this information out. And then, in the future, you can just imagine the research and the policies that can come out of collecting this data. Again, secure private data. This is for supporting our special populations and public health. That is kind of the core of why we do this kind of work, and the core of why we support work-related information. I think we are winding down. We have about 3 more minutes. Again, there's also the CDC's RCKMS for those technical people out there, the Reportable Conditions Knowledge Management System, which is the portal for public health reporting from clinicians and labs. And they have different occupations and diagnoses there that are, in fact, seen in research to be linked to specific occupations and exposures. So there, let's just checking to see if there are no more additional questions. I'm seeing none, but it doesn't mean that you can't send us questions after this LinkedIn Live. We are here for you again. I would like to again thank Dr. Michele Kowalski-McGraw for having us and speaking with us today in this LinkedIn Live. And we hope that now that you're wondering how your health center can collect and use this valuable information, please go to the NAC website, go to the CDC NIOSH website, and then if you need any more help, send us a message.
Absolutely.
So again, yes, absolutely. Our discussion, this whole thing has been recorded. It will stay posted on the NAC's LinkedIn page under events. Please do share it with your colleagues. You have someone working in physical medicine, rehabilitation, occupational medicine, share it with them, because I'm sure they will say, yes, I wonder why we're not collecting that as a structured form. So thank you again for joining us today in this LinkedIn Live.